Mild traumatic brain injury. It's something we see all the time in Australian primary and emergency care, right? But what about the dizziness that so often follows? For a lot of patients, it's one of the most disabling problems they'll face. Now, it's a complex issue for sure, but what if I told you there are specific, treatable causes that we might just be missing? That's exactly what we're going to dive into today.
For years, the standard advice has really been to just wait it out. But this whole wait-and-see approach is failing a huge number of our patients. So why is telling someone, oh, the concussion will settle, actually missing the mark for the very people who struggle the most? That's the big question we're here to answer.
First things first, let's get a handle on the sheer scale of what we're dealing with, because this isn't some rare, minor side effect. It's a really common and genuinely disabling problem that affects a massive number of people.
Just take a look at this number. Somewhere between 30 and 60% of patients who've had a mild traumatic brain injury will get dizzy or feel off balance in the weeks right after it happens. That's a huge proportion of these cases.
And for a pretty big chunk of those people, it doesn't just go away. 15 to 30% will have symptoms that just keep going, lasting beyond 3 months. This is what we call chronic post-concussive dizziness. And honestly, these are the patients who often feel left in the dark, without a clear diagnosis or a plan.
And this isn't just a footnote in their file. This has profound real-world consequences. We're talking about a leading reason why people can't get back to their normal lives, back to their jobs, back to playing sports, and even just back to driving their car safely. The stakes for getting this right are just incredibly high.
Okay, so this brings us to the heart of the matter, the outdated clinical thinking that can really lead to these poor outcomes. There's been a fundamental error in how we've traditionally looked at this problem.
And here it is. This slide shows a really crucial shift in thinking. The old question was so vague, is this patient dizzy from the concussion? It's a passive question, and it's what leads to that wait-and-see non-plan. The better, much more active question we should be asking is, which of the recognized mechanisms is at play in this specific patient? See the difference? This reframes the problem from one big mystery into a set of specific, solvable ones.
So what does this new framework actually look like? Well, it's built around 6 distinct, evidence-based mechanisms that can explain exactly why our patients are dizzy after a head injury.
And this is the key point. Post-concussive dizziness isn't one single thing. It's really a collection of different conditions. And the fantastic news for us as clinicians is that these conditions are not only identifiable, they're also treatable.
And here they are, the 6 mechanisms. First up, we've got traumatic BPPV. This is where tiny inner ear crystals get knocked loose, causing these brief, intense spinning spells. We can pick this up with positional testing. Then there's post-traumatic vestibular migraine, with longer episodes, often tied to a history of migraines. We have cervicogenic dizziness, which is more about unsteadiness that gets worse with neck movement. Then there's PPPD, a persistent unsteadiness that feels worse when you're upright or in visually busy places, like a supermarket. Labyrinthine concussion usually involves hearing loss on the side of the impact. And finally, autonomic issues, which cause that lightheadedness when you stand up. Each one has a specific clue we can hunt for.
Now, out of those 6, I want you to really focus on these 3 because they are by far the most commonly missed in practice. Traumatic BPPV gets missed simply because we don't look for it. We don't do the positional tests. Vestibular migraine is often overlooked if a headache isn't the biggest complaint. And PPPD, well, this one is so often mislabeled as just anxiety or some vague post-concussion syndrome, and that stops patients from getting the specific rehab they actually need.
All right, let's tackle the second major clinical myth, the role of rest. The evidence here has done a complete 180. What we used to think was helpful is now known to be the opposite.
Let this sink in for a moment. That old advice, the cocoon therapy of telling a patient to just go rest in a dark room, it's not just unhelpful. It is now proven to be contrary to the evidence. It can actually make recovery longer and drive those chronic symptoms.
This slide really says it all, doesn't it? We are moving away from the big red X of prolonged rest and firmly towards the green checkmark of a graded, supervised return to activity. This is the new evidence-based standard of care. Period.
So what does that look like in the real world? It means a very brief period of relative rest. We're talking just 24 to 48 hours. Then, a graded return to activity, letting the patient progress as they can tolerate. This includes gentle, subsymptom aerobic exercise. And, this is crucial, an early referral to vestibular physiotherapy if that dizziness isn't settling down quickly. That's the modern playbook.
Okay, so let's wrap this all up.
Let's summarize the key, practice-changing points that really form our new standard of care for these patients.
So if you walk away with anything today, let it be these 4 things. First, post-concussive dizziness is common. It's treatable, and it's not just one thing. Second, almost every case you see can be explained by one or more of those 6 mechanisms. And yeah, a lot of patients have more than one. Third, prolonged rest is bad for them. And fourth, the new standard of care is brief rest, then a graded return to activity. Simple as that.
Now that we know the why, the next step is the how. In our next explainer, we're going to get really practical and move to the bedside assessment. We'll cover the specific exam techniques you need to confidently spot these different mechanisms right there in your clinic.
Thank you so much for watching. To explore more about dizziness, vertigo, and imbalance, and to get your hands on some great resources for both clinicians and patients, please visit the website on your screen.